There we go. So our presenter today will be Dr. Terry Frankovich. She is a pediatrician with a master's degree in public health from the University of California, Berkeley. She has, over the past 25 years, worked in both urban and rural settings, and also academic settings and in private practice. Dr. Frankovich graduated from Calumet High School in Houghton County and returned to the UP approximately 14 years ago. Since her return, she has worked with the Keweenaw Bay Indian Community, Head Start, and she now serves as the medical director for 4 district health departments, including Marquette County, Public Health Delta Menominee Counties, Dickinson, Iron, and the Western UP. Between these health departments, serving over 10 counties and 10,000 square miles in Michigan's Upper Peninsula. So we welcome Dr. Terry Frankovich.
Thanks, Casey. By the way, the web technology is new for us, and so if you're running into problems with the audio or anything, just type in a question, and it'll tweak us to that. So thanks for signing in. We are basically going to go for about, I think, 45, 50 minutes, hopefully allowing some time for questions at the end. I'm missing seeing faces already, and I know a lot of the people listening in, and I can't throw chocolate, so grab your lunches to stay awake, and we'll go through this. If you do any questions that you have about the presentation materials, you can certainly type in as we go. We may be able to answer some of those in the process, and we'll try and answer everything certainly at the end, if not. And we can also respond to additional questions afterwards by emailing individuals. So what we'll do is for the presentation, we're going to turn off my webcam so it's not interfering with your screen in the slides, and we'll be walking through the presentation then here in PowerPoint. So welcome, everyone. Okay, so we're going to be talking today about lead poisoning prevention in the Upper Peninsula. That's my beach, by the way, in the photograph. Sorry, one sec. Okay. First technical problem. All right. So basically we're going to be doing an overview of lead poisoning, the exposures, prevention, treatment, and new recommendations about testing, which I think has been on people's mind who work with young children. So we'll start out with lead poisoning in general. We know that this is the most common environmental threat to a child's health in this country and is 100% preventable, as well as the effects being irreversible. So it's clearly a monumental public health issue and speaks to prevention. So we know that lead is common in the environment. We see it in soil, we can see it in water, we can see it in paint that remains in homes in our country. So lead does exist, and we know that in 2013, nearly 6,000 children in Michigan had lead levels that were at or above 5 micrograms per deciliter. Of course, in 1978, there were about 13.5 million kids in the U.S. with lead levels greater than or equal to 10. We have seen a decrease in lead exposure over time in this country, and that's been dramatically altered by things such as housing aging out, as well as unleaded or leaded gasoline no longer being used. So there's been clearly a dramatic improvement in the number of children who are lead exposed. However, the problem still exists. So when we look at who's at risk for lead poisoning, we know that anyone can become lead poisoned, but children between 6 months and 6 years are most at risk for lead poisoning. Children living in homes built before 1978 are at high risk, and particularly children in homes pre-1950. And that's because of lead-containing paints. Pregnant women, children adopted from foreign countries that may have different cultural practices, and different medications, different utensils, potteries, glazes, things used, can be a problem, and we certainly have seen things like recalls in this country for infant jewelry, infant child jewelry that's been made in other countries and painted with lead-based paints, for example. We know refugee and immigrant children can be at higher risk depending on where their country of origin is. So possible sources of exposure for lead for children, we know that, again, houses built before 1978 when lead in residential settings was banned, but homes before 1950, particularly high lead content is the potential there. Soil is a possible source of exposure as well, and when we look at old homes, soil around those homes that may have seen many years of shedding paint can be a big source. Glazed pottery and dishes, particularly from other countries, imported products, spices, home remedies, occupations and hobbies, pottery, glassmaking, etc., and water. And when we talk about water, we can be talking about municipal water, because we know that in some areas of the country, a prime example is Washington, D.C. They've faced significant problems with lead soldering in water conduits and had problems with lead poisoning for that reason. There we go. One sec, just a little trouble advancing here. What I did want to include here is this website that's listed has a more comprehensive list about occupations, hobbies, remedies, etc. that can lead to lead exposure. So that's there as a resource for you. So what ups the UP risk? Well, you know, we don't live around superhighways that have a lot of old deposits from lead-containing gasoline. And we don't have a lot of cultural diversity up here in terms of an immigrant population, etc., bringing home remedies and such that might introduce lead. But we do have some of the highest percentages of old housing in the state. So when we look at Michigan overall for pre-1950 housing, close to 25%. City of Detroit is the highest in the state at 62.2%. And I think, you know, we can certainly see with Detroit a lot of the decaying housing there that has potential for exposure. But our winner in the UP is Houghton County with 53.4% of homes pre-1950. So significant risk factor there. Macomb County was the lowest I could find in the state at 9.3. Interestingly, in Houghton County, at one point we were looking at whether we certainly knew that there was some issue with lead exposure, but considering the amount of old housing, it was curious that we weren't seeing higher levels. And so actually did some testing in partnership, the health department with Michigan Tech, as well as a Head Start agency for Baraga, Houghton, Keweenaw, and actually did a lot of lead sampling in older homes around Houghton County and found that, yes, indeed, there was a lot of lead paint there. So the exposure potential is there. I wanted to review a little bit about what we know with lead poisoning in the Upper Peninsula. One thing I wanted to mention, and I don't have it on the slide here, is how we're doing at testing for lead in the UP. I think likely everyone on the call is aware that the recommendations right now broadly are for testing children at risk at the age of 1 and 2, or once between the ages of 3 and 6 if they've not previously been tested. So one question is, how are we doing with that testing in the UP? So we pulled out some numbers from Michigan Department of Community Health for the testing of 1 and 2-year-olds, Medicaid children who are considered high risk in the year 2012. And we have quite a range in terms of our percent children tested over that year across the UP, ranging from about 43% in Chippewa County to, I have to give out Noggin a nod here, 100% of those kids tested. The range is really from the 40s throughout, 50s, 60s, several health departments in the 80s and 90s, and Mackinac second highest at 98.8%. So obviously, especially in a high-risk population, our goal would be to have all of these kids tested. When we look at poisoning in the UP, again, looking at the percent of pre-1950s homes, which gives us an idea about the amount of potential lead exposure. You can see that range there. The bottom line is Michigan at nearly 25%. And then I think only one or two in the UP are slightly below that range. Mackinac at 23.4, and we have Luce at 23.8. But most of the rest of the UP ranges in the 20s, 30s, 40s. So there's certainly a significant exposure risk there in terms of housing. What I wanted to point out on this slide is just our testing on blood lead levels. If you look to the right, the blood lead levels greater than or equal to 5 micrograms per deciliter, the percent of children falling in that range across our UP counties, you can see there ranging from about 0.8 or just under 1% for Mackinac to 4.4 and up to as high as 5.1 in Menominee of kids. So basically in Menominee, 5 out of 100 kids would be considered elevated in lead level. Obviously many fewer with levels greater than or equal to 10. Marquette approaches 1% there. If you look, actually Casey is going to pull up a Michigan slide here, a map. Just one moment while we change the screen up. So you can see here that with this map, it gives you just a sort of pictorial view of the lead testing results up here. So we're looking at the percent of children with blood lead levels greater than or equal to 5 in 2012. And you can see in the counties with the highest number of these kids who are at or over 5, Keweenaw, Houghton, Marquette, Delta, Menominee. With the blues gradually fading as the lead burden in terms of testing decreases over the UP, so everyone can kind of pick out their counties of interest. Obviously, we'd like that number to be 0, so we've got a little bit of work to do. Okay. Okay, so we'll resume on the PowerPoint here. So why are children so susceptible to lead poisoning? Well, we know first off that they absorb more of the lead that they ingest, about 50% more than adults do for a given dose. Their neurologic system is really developing rapidly during the first 6 years of life, and since lead impacts neurologic development profoundly, it's a very vulnerable time for seeing effects of lead. Also, just environmentally, children play on the floor more commonly, obviously. They pull to stand holding onto windowsills where dust tends to settle, and not only their fingers, but everything in the environment tends to go into their mouths. So they're sitting ducks to get exposure to lead dust. When we look at symptoms of lead poisoning, it contributes to the problem of lead not being recognized as an issue because they don't have any obvious external symptoms for the most part unless kids have marked toxicity. So the symptoms tend to be rather vague. Kids complaining of stomach aches, fatigue, decreased appetite, sometimes constipation, and things like hyperactivity we tend to see with more chronic exposure. So it's difficult to pick this up clinically, so it really has to be done from a screening standpoint. The health effects of lead, we know that neurons are particularly vulnerable to lead, and any damage that is done through lead exposure to the brain is permanent and irreversible. There are also potential effects to kidneys. It's nephrotoxic to kidneys, eyes, ears. Clear associations in the literature with decrease in IQ with increasing lead exposure. And we see a variety of cognitive difficulties as well as behavioral difficulties in children with lead exposure. From a societal standpoint, you can find research linking criminal behavior and childhood lead poisoning, antisocial behaviors, and obviously with children having cognitive issues related to lead and all of the other social sort of behavioral issues, there are welfare, educational, and criminal justice costs to having lead toxicity in our children. So the point being really with this that lead really impacts the entire community. What I put up here is a copy of old guidance that was provided in Michigan for provider offices who are testing children for lead. And probably a lot of the people on this call have seen this and are familiar with those guidelines that tell us that for children who have lead levels of less than 10, what the guidance was in terms of retesting, and then what recommendations were for intervening in environment. And I think most people were pretty comfortable with these and the testing patterns, but also know that things have changed up more recently. So this guidance actually is obsolete, although you can still pull it up online. So what's really new with lead right now? Well, in 2012, the CDC, Centers for Disease Control, came out with a report that really recommended eliminating the term that we had previously used, which was blood lead level of concern. We used to refer to that level of 10 as that level of concern. But again, as the slide notes, a growing body of research suggested that there wasn't an automatic elimination of risk when we looked at children who were lower than 10 on screening. What you could see is that there did seem to be continued association with lead presence and clinical impact. So large studies done looking at diverse groups of kids showed that even under blood lead level of 10 micrograms per deciliter, there was an association with lower IQ. And, that was irreversible. Also, the effects at blood lead levels less than 10 were seen in terms of attention issues and academic achievement for kids. And then, in addition, that you could see other physiological impacts of lead in terms of cardiovascular, immune, and endocrine effects. So really the idea being that we had in the past was that under 10 you were safe. And in fact, we used to report to parents when we got a lead level back that was under 10. Well, that's normal, essentially. And we didn't worry necessarily about any particular follow-up except doing follow-up based on age. So if it was a 1-year-old, we would repeat it too. And now that actually has changed because we know that there are clearly adverse effects seen even at levels below 10. So now the question is, who should be tested and how often should they be tested? So we know that Medicaid all along in Michigan has required that all 1- and 2-year-olds enrolled in Medicaid programs be tested for lead. So that was a given, and that remains the same at present. The Michigan Childhood Lead Prevention recommends that all children under 6 be screened for lead. So I know there's been some confusion in the past about what is screening. A lot of times we refer to lead testing as screening. But in this setting, what we're talking about are two different things. There's screening, which is a questionnaire that identifies risk, and then there's testing, which is the actual blood testing for lead. So when we're talking about screening, we know that certain things, for instance, low-income children who are enrolled in Medicaid, have a higher risk out of the gate of being found to have an elevated lead when they are tested. There I go. So we know that to be true, and that testing is required in Michigan. But what about all the other kids? We know that a child growing up, perhaps an affluent child, but who's in a 115-year-old home that's had renovations, may be at risk for lead. So the screening questionnaire is really meant to identify children outside the Medicaid population who may need screening, may need testing. I'm sorry. Boy, that terminology is ingrained. So the questionnaire that's very standard and you can find online at MDCH includes the questions that are listed there. Does the child live in or often visit a house, daycare, preschool, relative home built before 1950? Do they have a similar exposure to a home built before 78 that's been remodeled, creating lead dust within the home? Does the child have a sibling or a playmate with lead poisoning? Obviously with a sibling suggesting the home might be an issue. With a playmate, it may be somewhere that the child spends time. Does the child live with an adult whose job or hobby involves lead? And I have the asterisks there just to remind me, to remind you, that the web address for further information on those exposures is available earlier in the presentation. So does the child's family use any home remedies or cultural practices that may contain or use lead? Again, is noted at that website. And then does the child fall into any special population group, foreign, adoptee, refugee, migrant, immigrant, or a foster care child whose current home may not be the home they've lived in for the last 2 years. They may have gone through multiple homes, and you may not be aware historically of the age or condition of those houses. So right now we're in a bit of a state of flux in terms of lead. We can see that the American Academy of Pediatrics, the AAP, has come out with some guidance on basically what lead levels are to be followed up on and in what manner. Michigan's Medicaid program is looking at this guidance. What we're told is that most likely the Medicaid guidance will be very, very similar to this Academy of Pediatrics guidance that's out there. It seems to be a good working document at present, and we're looking forward to the final Medicaid policies on this to be released fairly soon. But right now, the recommendation even from MDCH is for providers to look at the American Academy of Pediatrics guidance on lead testing issues. So we're going to run through these here. Children currently, when we test them who are less than 5 micrograms per deciliter on blood testing, are essentially, the recommendations are very much like what we previously said for kids who were under 10. So instead of reporting, though, these results as normal to the family, what we're expected to do is to review those lab results with the family and basically note that our preference would be levels less than 2 in children. There's some range of lab error when you measure lead, and even the same specimen run a few times might come out with slight differences in micrograms per deciliter. But if our goal is an exam showing less than 2, then children whose results, for instance, come out at 4 on this first screen are not considered, technically without risk. So the recommendation here is that if the child is felt to be at high risk or there's a changing risk over time, that you might repeat that blood level in 6 to 12 months. If it's a 1-year-old, obviously you could repeat this at 18-month or at the 2-year well child checkup. But levels definitely should be completed at minimum at 1 and 2 years of age. If the child is initially screened at less than 12 months, for instance, if there's a sibling in the home who had an elevated level or there's some other risk factor present that caused testing earlier than 12 months, then you may want to retest at 3 to 6 months because obviously a child who's at, say, 8, 9 months is not as mobile as a 12-month-old or 15-month-old. And their risk in terms of their environment goes up with that age. Also, as part of a normal well child checkup regardless, there should be a general health assessment looking at nutrition, physical, and cognitive development, and also looking at iron deficiency risk factors. The reason for that is we know that iron competes with lead. Children who have iron deficiency are at risk to have a higher lead absorption. And so keeping children in a normal iron status is important if there's an ongoing lead exposure. And then we want to provide anticipatory guidance on common sources of lead exposure for that particular child, reviewing things historically in the family that might put this child at risk. So when we look at children who are 5 to 14, and this is going to be, if we have a child above 5, this is going to be the most common group that we will see, is in this 5 to 14 range. The recommendation from the Academy of Pediatrics is that you basically do those pieces that were recommended for kids who are under 5. But there's a recommendation to retest with a venous blood level within 1 to 3 months to ensure that the lead level is not climbing. And then if it is stable or decreasing, to retest in 3 months. So we're going to talk, it says here, about referring the patient to local health authorities. And we're going to talk a little bit at the end about the resources that are available in the UP and how those vary a little bit county to county as well. The other recommendation is to take a careful environmental history, looking, similar to what we did previously, to look at sources of exposure and ways that you could reduce exposure. To provide nutritional counseling, basically the things that are helpful are making sure a child's getting adequate calcium and iron. We know that we get better iron absorption when children take iron in conjunction with vitamin C containing foods, so citrus fruits. Vitamin C fruits combined with iron-rich foods at a meal are helpful. And they mention in here that some children may be eligible for WIC, and I think many of these kids are served in public health departments with WIC. We want to ensure that they are iron sufficient, and the AP actually does recommend laboratory testing for these kids who show at 5 to 14, and the labs mentioned there are basically to assess their iron status, a complete blood count, ferritin, and CRP. Not necessarily all of those are required for each child, but an assessment of their iron status is recommended, and considering beginning a multivite with iron depending on the child's intake. And then again, as part of a well-child check, we're always looking at developmental questions for children, trying to review those and make sure that kids are developing normally. However, there's some recommendation for more structured developmental screening in children if they have had lead exposure. For those children who are 15 to 44 micrograms per deciliter, the recommendation is again to sort of repeat the types of things that were recommended for the lower levels. But in this case, there is a recommendation to confirm the blood lead level with a venous sample and to have that done within 1 to 4 weeks from obtaining this result. I would argue that for most of us, if we're getting into those levels that are certainly up in the 40s, that should be happening very quickly. And I would argue even above 20, but at the latest within 4 weeks. People listening may be aware of the issue about capillary versus venous sampling. With capillary sampling, a finger poke basically, there is a greater risk of contamination on the skin, which confounds that lead level if the child happened to have some lead on the skin. Of course, that argues for the possibility that the child may have lead in their environment, but capillary blood is perfectly fine for screening purposes. But when we're looking at these children with elevated levels, a venous sample is recommended for follow-up. It notes on here that there may be some additional evaluation of the child recommended in terms of looking for lead in the gut, for instance. So a child who has a high level, who comes in perhaps with some GI symptoms and is known to have been recently ingesting paint chips, it may be worth doing a film to see if those are there, but that would be a decision by the primary care provider. And any treatment for lead levels in this in terms of chelation kind of therapy, which gets lead out of the body, is recommended to be done in conjunction with an expert. When we get to levels that are above 44 micrograms per deciliter, the guidance, all the previous guidance stands, of course, but confirmation with a venous lead level is recommended within 48 hours. These are the most lead toxic kids with these levels above 44. And certainly when we're talking about lead levels in the 40s, the possibility for managing these children with chelation therapy, essentially using either IV medication to try and leach lead out of the body, and that's done typically with hospitalization in symptomatic children, or with oral chelation therapy, Suxmer, which is given usually on an outpatient basis to asymptomatic children. Those are ways to decrease the lead level more quickly in children who have significant elevation, and that decreases obviously the length of exposure they have to those highly toxic levels of lead. Again, which path is chosen in terms of treating kids can sometimes depend not only on whether they're symptomatic, but also on family situation, compliance with medication regimens, that type of thing. in terms of whether it's done on an inpatient or outpatient basis. So again, treatment for children who have markedly elevated levels, and also for children who have mildly elevated levels, is to remove the child from the source of lead. That doesn't necessarily mean, of course, removing a child from a home, but it means remediating lead that the child is exposed to. Chelation is reserved for kids with very high blood lead levels, and typically we're talking levels in the 40s. And then usually some type of assistance for the family in terms of assessing the problem in the home and helping them with remediation of any lead exposures that are occurring in that setting. So these kids will often need referrals for additional types of services. Again, just to reinforce with chelation therapy, the recommendation, certainly from the Michigan Department of Community Health, is that providers utilize an expert who deals with chelation therapy in children frequently, because most of us, even in UP, are going to rarely see a child with a lead level that's in the 40s. It just doesn't happen very often. Dr. Kanta Bambani at the Children's Hospital of Michigan in Detroit is on the state's lead advisory group and is available for consultation on children who require or may require chelation therapy. One of the things that we've talked about at the state level in terms of lead and lead toxicity for children is that the public messaging on this, I think, has gotten a little lost in recent years. When we were detecting very high levels of lead in kids pretty frequently, when we were looking even decades ago, I think there was a bit more emphasis on this. I think now that we're looking at an issue where exposure has decreased over time, the lead levels that we're measuring are lower, I think it's become less of a focus in the primary care setting in terms of providing education to families and in public health settings. And I think we need to rethink that strategy, because with the research emerging that shows the link between poor outcomes and clear impacts on children's cognitive and physiologic health with lead exposure, we really need to be ramping up the message in terms of prevention. If we're talking about some portions of the UP having as many as 5% of our children having what we would consider significant lead exposure, then really we need to be getting a message out to families. So the message I think that we need to put out there is trying to emphasize to parents that if they have children in that under 6 age range, that their child should be lead tested at age 1 and 2, or again once between 3 and 6 if they've not been previously tested. We want families to understand that if they're in one of those older homes that is likely to have lead paint, that there are certified contractors out there who have been trained in lead abatement who can do this in a responsible manner. We also need to let parents know that if they're doing home renovations themselves, how they can do that safely. And there actually are materials available through the Michigan Department of Community Health, printed materials and online, that families can access to tell them how to do this safely within the home setting. When we're talking about removing shoes and work clothes before entering the home, we're talking about, in particular, parents who may have exposures in their work setting and may be tracking that material into the house when they return home at the end of the day. So simple instructions to parents can make a difference in the child's level of exposure. And again, families even knowing what year their home was built. I mean, I couldn't tell you with certainty what year mine was. And I think it's important if parents have young children to be aware of that. When we're advising parents about what to look for within their own homes, we're talking about things like chipping and peeling paint, not only inside the home but also outside. I think it's easy to forget that even in homes that have had remediation done internally, renovations, paint's been covered, that home may have had years of chipping and peeling paint on its exterior that has been sitting in that soil outside the home. And in fact, I can remember kids over the last decade that we've encountered who their primary exposure appeared to be playing in the dirt outside their own home. So it's an important reminder for families. And I like these pictures in showing sort of the conditions of windowsills, which I bet most of us have seen in homes locally, where there's a lot of fraying of paint, a lot of chips and dust that's available, and then that sort of crumbling exterior paint that you can see there that is either present in the soil in big chip forms that can be seen, but also there in ways that can't be seen. There are materials out there to advise parents on how to safely clean up or to do a cleanup if you have a child with a lead level, say, that is 7, and you want to be able to advise those parents if they're in an older home about how to do some cleanups to reduce risk. The guidance here goes through the products that you can assemble to do a cleanup at home, and I won't read through the list here. They do mention in step 2 a HEPA vacuum, and I note on here that they mention that the local health department has these. I'm not aware of any local health departments in the UP who have these, and you guys can correct me if I'm wrong. But certainly there are products that are sold commercially now that people can purchase in terms of their regular day-to-day vacuum that's a HEPA vacuum, but there are criteria that are listed there below that parents can look at, because if you're going to be vacuuming this stuff up, you need to be very sure that it's not spewing into the environment as you vacuum. So if a HEPA vacuum is available, families can vacuum windows and floors, porches, etc. with that before cleaning. But if not, certainly moist cleaning is the rule of thumb when you're getting rid of lead dust. So firm pressure has been shown to really decrease the lead dust burden on surfaces. So wet cloths that are used repeatedly, exchanging cloths, cleaning till you get a clean surface is really helpful to do even as a maintenance in some older homes. So when we're talking again about messaging to parents, I think is the message that needs to be out there is that really we know now there is no safe level of lead, that our goal is 0 essentially when we're looking at lead testing in children. And the CDC, with their new guidance that came out in 2012, has highlighted prevention as the most important thing for us to be doing with lead. I will note, however, that in addition to saying that, the CDC basically said, here's what we think should be done in terms of these new testing recommendations, using 5 as that cutoff level rather than 10, but they also noted that they didn't particularly have funding to support this. And I think that brings us to the topic of resources that are available to deal with the issue of lead in our communities. I have a few things on here. The Michigan Department of Health, Community Health, Childhood Lead Poisoning Prevention Program is a resource that's available both for materials that can be used educationally for families, provider materials, and these will be updated as the Michigan Medicaid guidelines are finalized for lead. And it is a great source for data as well about lead poisoning in specific communities. It's county level data. There's also a program, the MDCH Healthy Homes, and I put some information about this program on the following slide, and this can also be found on the MDCH Lead website. Basically, the problem a lot of us have faced in the UP, I think, is that we identify children who have elevated lead levels, either in the provider office or if a child is being seen at the health department, for instance, in a WIC clinic and has lead testing done. We get back a lead level that's elevated, and the question is, what do we do with that level? Whose role is it to work with this family to provide them with information, and in some instances to be able to do testing and remediation for lead exposures that are present? So a couple of things that we can look at for this. One is that with this presentation, with the AAP guidelines, we have some resource for guiding us on how to manage these kids in terms of retesting and what education is recommended. A lot of the materials that are out there about lead suggest contact with public health departments. Of course, public health departments in Michigan really aren't receiving funding for doing a whole lot of lead management services. It just doesn't exist. However, public health is able to assist a lot of times in identifying resources in the community, helping to provide some educational materials. And in fact, for children who are enrolled in Medicaid, there is reimbursement for a public health nurse to be able to do a home visit, to assess the environment and to provide some education on site. Now, this is not intended to be a testing visit where you're doing sampling of, paints and things like that, but it's intended to be a walkthrough, being able to identify for families things like how old is this house, what condition is the paint in, what kinds of cleaning things could be done to make it safer, that type of thing. The reimbursement amount for that visit is $75.90. I believe, at this time. So I know that when we're talking about the UP, where we have broad geographical areas to cover, 79 or 75.90, sorry, is not likely to cover the cost really of that visit to a home, but it's something. And in families who are needing some assistance, it is a reimbursement source. Across the UP, I think health departments vary widely. Excuse me, in how, in what they offer in terms of this service. And I think if you are within each community, I think providers tend to contact the health department for assistance and find out what's available. Health departments who do offer some assistance in this can certainly make that known within their community and on their website. But it certainly, we have that ability to do some education in the clinical setting. Oftentimes in health departments that's done in the WIC setting, but there is also the potential to do that home assessment for some reimbursement. This Lead Safe Homes program is based downstate. They do have some funding available to assist with evaluating the lead risk within a home and also doing some testing. They have identified counties downstate that are sort of a priority area because of the high level of burden of elevated lead levels in those communities. And in fact, when you look at the state of Michigan, I believe at least half of the elevated lead levels are in Detroit. So it does bear a huge amount of the lead burden within the state. But there are funds available to assist in other areas of the state, and I know that in the UP we have accessed this program. The last child I think we did access this for had a lead level that was in the 20 range, and the state actually sent someone up who went to the home, who met with the family, who did extensive lead testing within the home, and then prepared a report on the conditions in the home, the testing. The home was owned by a landlord, and that information was provided to the landlord regarding the remediation that was needed, resources, etc. So that is something that is available and worth contacting. I don't think we'd be able to get people downstate up here for kids with lead levels between 5 and 10. However, I do think with kids who come up with higher lead levels, it is certainly worth contacting them to find out if there's some assistance available for those families. And again, for families in need who may need some help with remediation in terms of the lead in the home, I think it can be very helpful to try and identify some funding sources for them. And that actually concludes what I was going to say in the presentation here today. And we can, at this point, I think, open it up for the microphones for questions orally, if anyone has questions at this time. I think I did want to point out that additional resources that are available are the toolkit that MDCH has been working on for provider information and parent information. That's available on the MDCH website, and it's also available on the Public Health Delta Menominee website as well. For people who are participating today, Casey will be able to send out some of this information in follow-up, as well as she will be sending a survey out to people regarding the information presented and any feedback that people have. So I'm going to open this up for questions right now. And if anyone has one, please go ahead and shout it out. Just tell us where you're from. Everyone busy eating? One question that came up was about chelation therapy. Again, chelation therapy is typically for levels that, most commonly used for levels that are in the 40s. The therapy, again, can be done either intravenously in the hospital typically or orally on an outpatient basis. Typically, IV chelation is done in children who are symptomatic with a high lead level, whereas the oral therapy is done on an outpatient basis in asymptomatic children with a high level. Again, sometimes where this is done in the manner also depends a bit on the social situation for the child and what's available out in the community. The recommendation, again, from public health is that providers who really have not done this in the past with children, that they should access the state consultant on this to provide them with extra guidance on the process. Any additional questions? And by the way, people can write or orally. Okay. All right. If there are no additional questions, then Casey's going to wrap things up here. Hold on one moment.
Okay. Okay, I just wanted to conclude by saying thank you for your participation today. I hope that you found this webinar format to be convenient. We thank Dr. Terry for her time today and putting this presentation together. Again, she mentioned there are a variety of wonderful resources available, different websites that you can go to. Again, I just want to encourage you to check out the website of ours, phdm.org. Click on the lead link, and it will bring you to that toolkit where you can download those materials. They're all PDF documents. Also, if you are having trouble downloading them or you don't have maybe the printing capacity, you can definitely just let me know, and we can mail out those resources, or I can put them on a thumb drive for you and send that to you so you can have those electronic copies as well. I just wanted to remind everyone that this webinar was recorded today, so you can go back and review it if you would like to. Also, if you think you may want to share it with a colleague, please do that. You can just go ahead and share the link. I'll send that in an email after the presentation as well. And finally, Dr. Terry mentioned that there will be a very brief survey. I can send that out. I just really would love to hear your feedback, since this is the first time that we have tried this webinar format. So let us know what your thoughts are. It's a very quick, really should take you only about a minute to complete. So I'd really appreciate it if everyone that participated could do that for us. Again, if there's additional questions that you didn't have an opportunity to ask today, feel free to email me and I'll forward them on to Dr. Terry and we'll get you a response when we can. So one more time, any other questions?
Thanks very much.
Thank you. Have a good day.